Welcome to Mayo Clinic Q&A. I'm Dr. Sanj Kakar. In the United States, racial and ethnic minorities are at an increased risk of getting sick and dying from COVID-19. Why is this the case? Where you live, what type of work you do, and whether you have access to adequate healthcare can affect your risk for COVID-19. A recent publication from Mayo Clinic researchers looked at the disproportionate impact of COVID-19 on racial and ethnic minorities. Joining us to discuss this today is one of the authors, Mayo Clinic infectious disease expert, Dr. Aditya Shah. Welcome to the program, Dr. Shah.
Hi, Dr. Kakar. Thank you for having me over.
It's a real pleasure. Before we dive into your wonderful work that you've done, what do you mean by health disparity?
Sure. So health disparity means that a difference in health outcome that is closely linked to your social, economic, or environmental situation. Certain patients or certain populations have disadvantages in their social, economic, and environmental spaces that set them up for poor healthcare and poor health disparities, which some other people without those disadvantages might not have.
So you touched upon that in terms of the disparities, and you said that COVID-19 disproportionately affects people. Can you explain that a little bit to us?
Sure. So when we started the pandemic, when we started taking care of patients in the pandemic, we first started to see what kinds of patient populations are more affected. So we have clinical data coming from New York, coming from China, coming from other countries affected, that patients with comorbidities like high blood pressure, diabetes, hypertension, kidney disease, lung disease, heart disease are at a high risk for having these more serious infections and even mortality. We then tried to look at, is there any difference in socioeconomic, environmental, genetic backgrounds for these patients? And we found that a report that was brought out by the CDC in June of 2020 showed that 21% of cases are now of COVID-19 in the US are in the African American population, and about 33% of the cases are in the Latinx population, despite these two populations making up only 13 and 18% of the US population, respectively. And as you may know, race is always underreported in these patients' populations. So I'm sure that the actual number or the actual impact is actually higher than this. We also then saw that the median income of a Caucasian or a white family is almost 10 times that of an African American or a Latinx or a minority population. So we started to research and to see if these social, economic, genetic, and environmental backgrounds are setting these patients up for having higher chances of getting infected, higher chances of getting more severely infected, and higher chances of mortality.
And so what did your research show?
Sure. So we saw that there's a close interplay of environmental factors and host factors that come into the picture when we are discussing COVID-19. We found that environmental factors, especially systemic racism, problems with housing density, these populations living in areas which are more dense than other populations, these patient populations having a higher chance of job insecurity, living in environments which are more prone to pollution, working in essential industries, right? You and me and others can quote unquote work from home, but if you're an essential worker who's driving the subway or the bus, you may not have that capacity to quote unquote work from home. This, in addition to inability to distance because of living in dense populations and heavy reliance on public transport, are some of the environmental factors that set these patients up for having more infections, or these populations up for having a higher chance of infection. This, when it is correlated, or this when it is mixed with social determinants of health, which, as I mentioned, economic gaps between the Caucasian or the white population and the African American or the Latinx or other minority populations, when these two things come into play together, it essentially leads to a perfect storm type situation, which predisposes these patients from having these population from having more chances of infection.
So one thing I wanted to sort of dive down a little bit, when you look at the global map, for example, the COVID-19 rates vary. So for example,
Mm-hmm.
if you look at Africa,
Mm-hmm.
say to the United States, and so they obviously have different environmental and social factors and genetic factors. Can you explain to us a little bit why that may be the case?
Sure. So each patient, each population is different, as you mentioned. An interplay of many Southeast Asian countries or African countries are that their their populations are younger than the population in, say, the United States or Europe. They're also more stringent implementation of masking and social distancing and lockdowns, which are more stringent in those populations than, say, in the US or European populations. We also have a higher, about 35 to 40% of Americans are at some level of obesity, which we know is a high risk factors for having more serious infections because of COVID-19. So these are some basic differences that come into play. But if we look at the US patient population in particular, we know that African American and Latinx patient populations have a higher chance of comorbidities like hypertension, kidney disease, lung disease, heart disease, diabetes, obesity. They also have poor access to healthcare, which other populations may not have that issue. And because of this, because of their health being neglected for a long period of time, and because of their social and economic situations being suboptimum for a long period of time, they're essentially a cohort of patient population which is just set up to not do well in this pandemic.
So, as you mentioned, there's several factors with interplay there. Can you tease out which factor do you think is the most important, be that environmental, genetic, social? What would you say?
In my view, and this is my view, I think the social factors are the biggest problem here because we do know that for almost every disease, there's more poor outcomes in the minority racial populations that we discussed. And this has been the case not just for COVID, but for any other disease that you pick, the other diseases that I mentioned. And these are because of years of neglect of these patient populations and because of not, in my view, not acknowledging that there exists a problem. I think if we want to solve a problem or make a dent in it, we first need to acknowledge that that problem exists. So if we did not have social conditions that would predispose these patient populations from having poor environmental factors that they grow in, or genetic factors that they get born in, then we would not have the outcomes that we are having. So in my view, I think the social factors are the most important factors, and that should be the first thing that we must try to deal with, and then that will lead to trickle down improvement in environmental and genetic factors, not just for COVID, for literally any disease that you can think of.
That's great, Aditya. Anything else that you wanted to add?
Sure. So I wanted to emphasize that there's two aspects to this, right? There's a social situation, and then there's what can we do as clinicians. I think the pandemic gives us an incredibly important opportunity to be at the table with the politicians. Now, we are not policy makers, but I think as clinicians, since we're at the table, we need to highlight these problems that exist, and that is one thing that we have tried to do with this publication. Now, what happens when we are taking care of COVID-19 patients belonging to these minorities in the hospital? There's a few solutions that we propose for this as well. One of them is standardized treatment and management protocols for these populations. Another one is having community engagement between the healthcare system and the local community, like we have from Mayo Clinic and the Rochester Health Community Partners, to have a collaboration between community leaders and hospital leaders to improve access to testing, improve access to treatment, improve access to post-hospitalization care. So that's important. Lastly, dealing with implicit bias as clinicians. Now, this is a topic which is hard to deal with because implicit bias is challenging because of its definition. It is implicit. We may not know it. There's only so much that we can do by, making modules for training and such. But I think we need to realize that if we see a patient, not just of COVID, any disease who belongs to a racial or a language minority, we must understand that they must have had societal, environmental, and genetic factors that have led to their poor health outcome that we are seeing them for. And to just give them additional support so that we can tide them through the illness and also help them not be admitted for any other illness in the hospital in the future. And lastly, I know COVID fatigue is real, but it would be criminal of me to not reemphasize that masking, social distancing, hand washing, not touching your mouth, nose, or eyes is very, very important, especially as we approach the holiday season, Halloween, Christmas, etc., etc.
Yeah, very well said. One of the things that you mentioned was about standardized treatments.
Sure.
Can you explain that a little bit more?
Yes, so if we are seeing a patient population, so at Mayo we have a COVID treatment panel, and if we have a patient who is belonging to a language minority and there's a communication gap between so many treatment modalities that we can offer, whether that is standard of care treatment like remdesivir and dexamethasone, or there's research treatment, it is always challenging to offer these patient populations that particular treatment because of it being lost in translation. So we have a group of translators who help us work with the research assistants and the research teams and the treatment teams so that we can have to the patient all the available options on the table so that they can make an educated decision. We are also having colleagues who are language translators so that they can help us in post-hospitalization follow-up to make sure that when these patients go home, A, we have a phone line connection to them, and B, in a language that they understand, so that if they are getting worse with regards to their clinical condition, they don't need to wait till the absolute last minute till they come to the ER. So we have language services at Mayo, which we're working closely to help with that. And we have close follow-up of these patients even before they come to the hospital. Like if they're mildly asymptomatic, we have a communication channel available with not just with them, but with all patients to make sure that they continue to improve clinically.
Thank you. We've been discussing health disparities in COVID-19. Our thanks to Mayo Clinic infectious diseases expert, Dr. Aditya Shah, for joining us today. Thank you very much, Dr. Shah.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on podcasts. Thanks for listening and be well.